Well, I want to thank everybody for coming. My name is Joe Manley, and this is Kate Hicks. And again, we want to welcome you to what we are calling the healthcare crisis, Student Nurses for Change. Our group consists of nursing students here on the Missoula campus that are going to be graduating and going into the healthcare profession sometime after that. But before I talk to you more about ourselves and how we got to this point, I want to pose two questions to each and every one of you, because I think the answers that we give will really define who we are as a society. And the first question that I want each and every one of us to think about is healthcare a right or is healthcare a privilege? Because those are really two distinct words, and I think we need to look at that to see if our healthcare is a right or if our healthcare is a privilege. The second thing that I want to pose to you all is healthcare about the bottom line and just the cost, or is it about doing the right thing? And again, I think those are very important questions that as society that we need to deal with in order to really make change happen. Well, again, we are nursing students here on the Missoula campus, and this project started last semester when we knew that we were going to have to do a project for Teresa Henry's health policy and economics class. And so this semester we viewed the movie Sicko in our health policy class. And for anybody here that has viewed the movie Sicko, it's a very controversial movie, and it gets people to talk. And it really made our class talk about what is the state of our healthcare system that we are going into. And I think that was the big impetus behind bringing people here together to talk about our healthcare. So the idea behind today is to not only generate thinking and discussion, but more importantly, to consider solutions. I think we all realize that our healthcare system is not the best that it can be. And Kate and I were pretty adamant about not just focusing on how bad our healthcare system is, but we really wanted to focus on solutions. But we also know that in order to hopefully make changes in the future, you also have to understand the past and how we got to this point. So I'm sure we're going to talk a little bit about how we got to here. So what we did as nursing students, we brought this panel together with various expertise to consider the 4 questions that we're going to talk about today, which we feel is going to provide a context for this discussion. We're also very lucky to have 2 professors who are also experts in the nursing field and who also have various other degrees in the nursing field as well. So how this is going to work, at the start of each group of discussion questions, these 2 professors are going to be giving us a little more insight into the meaning behind these questions. Specifically, one teacher is going to talk about what is healthcare access, and another teacher is going to talk about the concept that is called upstream thinking, which has to do with promotion and prevention. Okay.
So I'm going to introduce our panel members. Is this working?
I think it is, yep.
Okay. I'll start with the man closest to me here. This is Larry Riley. He's a partner at Garlington, Loan & Robinson and practices as a trial lawyer with a special emphasis on medical legal matters. On the community level, Larry has served on the board of many community-based organizations, including Camp McAdream, the Institute of Medicine and Humanities, the March of Dimes of Missoula, and was the founder and initial president of the board of directors of Big Brothers and Sisters of Missoula. Welcome, Larry.
Thank you, Larry, for coming.
Next, we have Mary Jane Nealon. She is currently the Director of Ancillary Services at Partnership Health Center, where she oversees the Ryan White, breast and cervical health, healthcare for the homeless, and access to therapy programs. She has worked as a nurse and writer for 32 years. She has worked in clinical research in university hospitals and with the homeless in New York City. Next, we have Ron Dusnip. He is the president and general manager for Allegiance Benefit Plan Management and Allegiance Life and Health Insurance Company here in Missoula. Ron has been involved in the management of employee benefits for over 25 years. Welcome, Ron. And next we have Susan Kohler, who is the CEO of Missoula Aging Services. She has 29 years experience in community development, nonprofit management, and senior advocacy. She has served as a representative to the White House Conference on Aging and will attend the National Center for Long-Term Care Business and Strategy Workshop for the Aging Network at Scripps Gerontology Center next month, where she will present her innovative approach to providing services with limited resources. And last but not least, we have David Kendall, who is the Senior Fellow for Health Policy at the Progressive Policy Institute, which is a think tank based in Washington, D.C., wherein he telecommutes from Missoula, lucky for us. He has written book chapters, including one in Building the Bridge, which is 10 basic ideas to transform America, as well as many articles and reports about health policy. In 1993, he served on the President's Task Force for National Health Care Reform. Welcome to all of our speakers.
Yeah, thank you all for coming.
Thank you very much.
And so now I'd like to bring up Kate Seacrest. She has her Master's in Science in Nursing. She's a certified nurse midwife, and she's also an adjunct assistant professor at Montana State University College of Nursing here on the Missoula campus. She has worked in a variety of settings, both rural and urban, delivering direct care in the community and acute care settings. She currently teaches community and public health nursing here on the Missoula campus to us, and she's going to be giving a brief explanation on what healthcare access means, which is going to really frame our first two questions. Thanks, Kate.
First of all, I'd like to thank Kate Hicks and Joe Manley and the other students that are involved in bringing this event together. I am privileged to be part of the academic team that's been working with these students as they are getting very close to graduation, just a few weeks away, and are going to enter the profession of nursing. I think healthcare has always been a career choice that is exciting and challenging and rewarding, but I think that this is a particularly dynamic time. Just the fact that it's an election cycle and that there's an increase, there's a swell of national attention on healthcare reform, on universal access to health insurance, on preventive care, on even how we define what we mean by health. Is it lack of illness, or is it maximum capacity? So there's a lot of discussion, there's a lot of debate going on, and we need leaders like these students to come into the professions, the multidisciplinary professions that are working on this together, with ideas, with energy, with their intellect and their hearts, to work together to come to some ideas about how we can make things better. So thank you. And they asked me to make a few comments on access. I mean, it's an extremely distinguished panel. They're going to be talking about this in depth. So it wouldn't surprise my students at all to hear that I went to Healthy People 2010 to think about access. I'm always sending them to Healthy People 2010, which is our structure, our national objectives for prevention and for health. And one of the focuses of Healthy People 2010 is access to high-quality health care. And it's also one of the 10 national leading health indicators chosen by Healthy People 2010. So access, it's all about access. And when I looked at that, and Joe and I had talked a little bit about access, and I don't think anybody's going to argue that access has a whole lot to do with health insurance. I don't think there's any question about that. And I think you'd have to either have been, hibernating or, been on a remote island somewhere for a long time if you're not pretty familiar with some of the statistics that are going around on this political season. We got 47 million Americans, 9 million of which are children, that are uninsured, and these numbers are rising. This is important. But it's not just when you're given a questionnaire, do you check the box, I have health insurance, or I don't have health insurance. Is your health insurance sufficient? Is it an adequate health insurance? Can you afford the premiums? whether you're buying it on your own or whether, like many of us, we pay a premium and our employer pays part of the premium. Those premiums for their employees are on the rise. Can we afford these concerns? Can we, are there problems with the deductibles, with the co-pays? Are there conditions that are important to you and your family that may not be covered by your health insurance plan, either because it's a pre-existing condition or there may be another reason why it's not a covered condition? Preventive care, is that covered by your health insurance plan? And how do they term what's covered under the area of prevention? You may have considerations about whether you have pharmacy coverage. And if you do, does it happen to cover the pharmaceutical agents that are important to you and your family? I mean, I personally discovered that my health plan, which I consider to be quite good, didn't cover brand names. It has to be generic. When I went to get my son's medication, they said, well, it's not covered because it's not generic. I said, is there a generic of this medication? And they said, no. And I said, well, I'm sort of caught, aren't I? And wrote the check. But, you know, I'm able to do that, but where does that line drawn? So what is health insurance and what is adequate health insurance? And there is also access issues around what they call structural issues. And in a rural state like Montana, well, it's nationally it's a concern, but you think about it in a rural state like Montana, are there primary health care providers that are available that will take your health insurance if you have health insurance? Are there specialists that are available? Think about some of the data on Montana and Missoula County and mental health practitioners. So are there the specialists that are available? Are there facilities, hospitals, emergency departments, clinics, surgery centers, whatever, to deliver the services in your community? And then certainly not least, but finally, are some of the personal access issues. So when you think about personal access, you think, are there barriers, cultural barriers, language barriers? There may be a perceived or real concern about discrimination or confidentiality concerns if you go for a certain condition or a certain health concern. You may be living with a disability, either a physical disability or an intellectual disability. And finally, can you figure out how to access this complex system? Do you know when, where, how, who to ask for help, even if you have the benefit of health insurance? Do you know how to navigate the waters of this complex system? And once again, when I'm doing this for my young family, I throw my hands up sometimes and say, I don't know how somebody without the insider perspective I have manages this. It's complicated. So there's layers to access. And I think we do talk a lot about health insurance, but I think it's a bigger issue than that. And I really applaud the students for saying this isn't about, I can stand up here and say, these are all our concerns, and we have a panel of experts, and we can talk about what's wrong. But I really appreciated Joe and Kate and the other students saying, we want to start and continue the conversation about what can we do to make it better. So I really appreciate that, and I appreciate people coming and continuing this conversation, and I'm really anxious to hear what the panel has to share. So thank you very much.
Thanks, Kate.
Thank you, Kate. Well, with that framework to think about healthcare access, I'm going to present the first question, and it'll be directed at Mary Jane for some introductory comments. And the question is a big one.
They're all big.
They're all big. How can our nation make health insurance equate with equal healthcare access?
Okay, well, I certainly agree with the statement that, can people hear me? I'm pretty loud. I'm from New Jersey. But
Thank you.
I think that people could all have insurance cards in their pocket tomorrow, and that doesn't mean they would have access to anything. As I'm sure Susan Kohler could attest to better than I, Medicare is the perfect example. People have coverage, but the reimbursements are meager. Providers have the option of saying they're not going to take any new people, and frankly, we don't have enough providers in this town or in many towns that I've worked in. So I think, you know, that the insurance coverage is part of it, but I think the bigger picture is how do we structure a system that rewards people who participate in it? I really applaud the nursing students. When I talked to them briefly at the health department, I said, there's no reason to ever be burned out as a nurse. I'm a poet, and I feel like that feeds my creative energy for my job. I usually walk around when there's a problem singing If I Were King of the Forest until I solve the problem. And I think that that's what we have to do. When we're hearing during this campaign discussion about healthcare, it's really exciting to me, but I want to fire questions at them. So one thing that I think is critical are your community health centers throughout the country. We already have a network of national community health centers. Partnership is a federally qualified community health center, which means that we devise a work plan and a 5-year strategic plan for healthcare. Healthy People 2010 is our map. I saw the other day lots of things on Healthy People 2020, so I assume we'll have to go in that direction soon. But I think when people do have insurance, figuring out how to support community health centers so that people can get access, we already know how to make things happen on a shoestring. We already have a lot of problem-solving abilities to keep costs down. So that's huge. The other thing about access is I don't think we can separate it, and I wouldn't begin to talk about the legal issues with the other members of the panel, except to say that federally qualified health centers are covered under the Federal Tort Claims Act, which limits the amount of liability and cost, and you don't get caught up in endless lawsuits and have to pay a lot for individual providers. Your providers have the comfort of working knowing that there's a larger body protecting them. So I think that's huge. I was a traveling nurse for 6.5 years, and I worked in Shiprock with the Navajos, rural Louisiana, in city trauma in Savannah, Georgia, Hawaii, the prison unit in Baltimore. And I don't think that there's one solution that can serve all these areas in the country. All of those communities were underserved. During that time that I worked there, and a lot of my colleagues that I met as a traveling nurse, we were not participating in a pension plan. So I feel like anyone who serves the underserved in this country should be part of a government pension, whether it's the same as federal workers or anything. I'm not sure. But I know that I would have continued to do that for 10 more years. It was fascinating to see the way the healthcare system in different parts of the country solve their problems. But I started to think, I was in my 30s, I had to figure out a way to plan for my future. So I think that's critical, because for young nurses, you grow a fabulous young nursing group of confident people. You get into an underserved area, you get a 24-hour orientation, and then you are usually in charge. And so you become a problem solver. And that, it also alerted me to, I grew up essentially in New York City, across the river, was over there all the time, worked in New York City, and I saw everything through the lens of urban problems. And it was only when I got to rural Louisiana that I realized the things we did in the city didn't work. And so having that perspective, I think, is important, that we not have something like Medicare D, which is a nightmare, get pushed through in Washington, and then have the frontline people trying to solve it. I don't know how much people know about Medicare D, but it's disastrous for those of us that are working in the field.
And Mary Jane, you talk about the underserved populations. Can anyone else on the panel address that? How can we get health insurance to those people, and would that help, do you think?
I'll address it from an employee benefits standpoint, if I can. My background, again, as an employee benefits, I was the manager of employee benefits for a large healthcare company. And then I went into the consulting field and worked with several states and also some significant public companies. And I'm now in Montana. I was in Ohio for about 15 years. I'm now in Montana. And I've been here for about 3 years, and I have served on some national committees. So the background that I'm coming from is from an employer-sponsor type situation. And we've got about 62% of the adult population, non-elderly, that's covered by employer coverage. There are some significant areas of the uninsured who are employed. And there are three groups that we really need to work with. The first one is the self-employed. Self-employed have two issues to overcome. One is individual insurance has a tendency to deal more strictly on an underwriting basis with individual problems. So we need to work with broadening the risk base for the individual pool. The second problem that the self-employed have is tax problems. Now, it's being addressed slowly, but it's not being addressed as quickly as it could be. If the self-employed had parity with the employed otherwise in terms of taxes, they would save an additional 20-some% in some areas. We've got a significant population in the part-time employed force. And that's something that many employers have pulled back on because of the cost of covering the full-time. But interestingly enough, the cost per individual as the pool shrinks goes up, whereas the cost per individual as the pool expands goes down. Now there's pardon me, I've got a background in economics, so the marginal rate of return for the addition into the size of the pool kind of caps out after a while. But again, bringing some pooling in there would help a great deal on the part-time. The last group is an interesting group for the student nurses. The most underserved employed population is the 18 to 24-year-old. They're also the demographic that chooses not to enroll the most often when they have enrollment opportunities. Now, the interesting thing about the 18 to 24-year-olds, they seldom cost anything until they cost a lot. It's the motorcycle accident. it's the development of leukemia. It's those types of things that all of a sudden, we're not talking about paying the $150 for well care over the course of a year. We're talking about $250,000 bone marrow transplants, or we're talking about $500,000 reconstructive surgery after a motorcycle accident that's not covered under perhaps collision insurance. So I think three areas that we really need to work on to create a greater service toward at least the employed population would be parity in the tax for the self-employed. The state of Montana actually increased the requirement for insurance companies to cover dependents up to the age of 25, and that was at 19. Now that's up to age 25, so that helps with the 18 to 25-year-old population. The part-time population is one of those where I don't know if my colleagues in my particular part of the industry would agree completely, but creating a larger pool and having those part-time employees participating. I know, for instance, when I was working with this large healthcare institution, we offered benefits to anybody working 20 hours a week or more, but from 20 to 30, they did pay twice the amount that the the full-time workers paid. Now, interestingly enough, when I say twice the amount, the full-time workers were still only picking up 10% of the total overall cost. So I do think there is something out there that many of the employers have expressed some frustration with. They don't know exactly how to explain that, yes, on average, it's $7,000 per year per employee, and most employers are picking up somewhere between $5,000 and $6,000 of that annual cost. So that's a significant addition.
Yeah, I've read it somewhere that the average cost for a company that has over 200 people is $12,000 per person. Is that?
That would be correct for the family coverage.
Okay.
If you take the single coverage, the family coverage, blend them all together and divide by the number of enrolled employees, that's how you come up with the sum. And in fact, that's probably a 2003 or 2004 figure.
Okay.
It's closer to 13.5. Now, one of the other things is the larger companies above 200 and so forth do have, generally speaking, a richer benefits program. I apologize.
And tax breaks, right? They have better tax breaks.
Tax breaks are essentially the same.
Okay.
They have a different impact because of the size of the organization and therefore the size of the revenues. But the percentage is about the same. Now, the one other underserved portion are the number of people who work for small employers, those less than 25 employees. It's an extraordinary expense on those smaller employers. One of the things that has been discussed in several different Congresses, been passed by the House several times, has been held up in the Senate a few times, is association-type health plans where smaller employers can band together and get the advantages of that larger employer pool. Because if you've got a 25-person shop and one person has heart problems or has a leukemia situation, you don't have enough premium coming in from 25 people to cover the cost. And it's interesting, we did a study for one of our clients fairly recently. They've got 17,000 plus covered employees and their dependents, and 7% of their population accounts for 75% of their costs. And that's the kind of thing that shifts. And unfortunately, it's not the same 7% each year. It does shift from year to year.
And I think that's kind of the national problem. It's not just employer-based insurance companies that are dealing with this. That's kind of nationwide. There is a very small percentage that have a significant amount of the medical problems. But at this point, I think we're discovering that it's not a, or we and us thing. It should be about, everybody working together to care for one another if we're going to be, on top of this. What do you guys think about that?
Well, I appreciate that very much because having seen sicko, sometimes the insurance companies are seen as the bad guys. Now, I will admit there are abuses in the insurance company system. There are. I wish there weren't. I hope that I represent the group of us that I think is the vast majority that aren't doing that kind of thing. If you're talking about the general primary care type coverage, then it becomes more of the structural and complexity access that's the problem rather than the coverage access that becomes the problem.
And I'm sorry.
No, go ahead.
Well, I guess then I have a question along those lines about a structure and coverage. And I know I was talking with David when he came to talk to our class a couple weeks ago that in February, this article was making the rounds in all the different news services. And CBS News says, Blue Cross to docs help cancel coverage. MSNBC.com says Blue Cross quits asking docs to rat out patients. In the statistics that I've seen, and those aren't important. I mean, I've read that maybe there's 100 million people with pre-existing conditions in the country, and I mean, I guess we don't have to debate that, but how do we get our health plan to cover everybody? And so there's no choice. Okay, everybody's going to have, because I know with pre-existing conditions and sick people, insurance companies need to make money, physicians need to make money, but how can we balance it out that everybody has coverage and not just a few? Susan, go ahead.
I guess I'd like to take a different slant
Great.
at this, if that's okay.
Nope, that's great.
And I'm assuming in a lot of ways that there are no barriers, and I think one of the things I see is that we just have to quit focusing so much on the existing model and how do we tweak it, but a significant redesign or complete redesign of the model. In my personal opinion, there shouldn't be anybody young or old that has to go to a community health center versus a clinic. I don't know, I don't quite understand, and some of this is because I'm naive in many ways, why do VA veterans go to VA hospitals instead of regular hospitals? A system should support from young to old. I think you're talking about economics, is from my understanding is that if you support kids being healthy and going to school and not missing school because of health, getting in the workforce, et cetera. Does that mean on the total question, or just you're showing it
Just
to
on
me?
this question.
Yep, just on this question. Not just, yeah.
Okay, I was like, you know me too well. you know, that a country's wealth is more based on a healthy society actually generates a wealthy society. And so should be a lot of incentive to retool a system that does from birth to death. The other thing I think we tend to bury our heads in the sand about is, you know, we're talking about employee-based and things like that, and the reality is I'm a baby boomer. I'm part of the largest demographics in the country. I like it that people like myself always say, well, the baby boomers. Well, that's me. And we tend to define every decade we move into. And I like to coin the phrase, the silver tsunami that's coming, and what I figure is about 2025. Medicare is established, and I really think that an insurance system, instead of dismantling Medicare, it really was an introduction to a healthcare system that really could benefit everyone. I mean, Medicare's been around for 40-plus years. Clearly, it needs to be looked at and redesigned. But the overall concept, which is, you know, they have the arbitrary age of 65, but whether it's birth to, again, death, the whole idea of having access to health care. The other thing I think you can't ignore that a majority of our population, and we're having the historic shifting of demographics. So we can talk about employee-based systems and things like that, but the reality is there's a far larger population moving into the aging population than there is a younger population. In the state of Montana, by the year 2025, we're supposed to be the 5th per capita in the country in terms of the percent of population that's aging. That's huge. And even in Missoula County, the statistics show that we're not getting growth in the young families. The only growth that we're seeing here in Missoula is the 65 plus. And so when we're talking about land use, access, housing, you know, we got to be talking about the realities of that demographic. So when we look at access to health care and that whole model, I think that, you know, I'm glad and grateful that we have community health centers. I'm glad and grateful that I have health insurance and others could have it. But it really should be some form of universal. When you have over 1,500 insurance companies, just the administration of that alone, you have to believe you'd have some kind of cost savings that could be put into it, into that kind of a universal system than to have. And I know there's a balance between private and public. And the question is, what is the role of government? You know, one of them is to take care of its vulnerable citizens, and there's a debate about who is vulnerable, especially when it comes to health care. And so I think looking at access, and since we're probably down to T-minus 30 seconds, and I really had a lot more I wanted to say about this, and we'll probably squeeze it in inappropriately in other categories.
Go ahead, Susan.
But, you know, we have to be looking at the realities of the demographics. And access, I mean, we have one of my favorite people, I'm supposed to ignore that. I was instructed by the people who are in control, and I'm sorry. You know, we have to create geriatrics in this country. We created pediatricians because of baby boomers. The healthcare system does not. There's no incentives for whether you're nurses or allied health or any other aspect, social workers, to get involved in geriatrics. When, you know, whether you like to work with that population or not, you're going to have to. And that it's going to affect a community as a whole. This is not just the job of the medical community and people wanting health care to deal with. We each have to take our own personal responsibility towards our own health. How do we provide incentives to do that? How do we build communities so staying healthy isn't a major issue where we have walkways and pathways? How do we divert people out of nursing homes? How do we change that whole to home and community-based systems and not make affordability an issue? You had asked a question about a right versus a privilege or whatever it is.
Yep,
I mean,
privilege or a right.
a privilege or a right. Well, clearly it's a privilege. A privilege currently is privilege of people who are employed, people who have health care versus, and I think there'll always be the haves and have-nots. I mean, people with money will always be able to purchase more than the average person if they choose to. But it is a right. It's a basic human right, as education is. Everybody should, not based on income, whether they're working or whatever. We just have to have an entire shift. I think looking at how to tweak a system is like trying to turn a big ocean ship out in a hairpin turn. But it's time to start moving the ship because it's broken. So we should stop talking about what the system currently is. We need to talk about how we want to make it.
And
Thank you.
Susan, that's a great transition. Thank you. Our next question is kind of along those lines of how are we going to pull this off? And one way that I know us as nursing students have been told is evidence-based practice. So our next question I'm going to pose to David Kendall. How can our nation ensure that healthcare access decisions are supported by evidence-based practice instead of profit interests?
Well, thanks, Kate. And I wanted to say also to the students here and for leading this organization, you guys are doing a great job. We have to have the idealism and enthusiasm to replace the many efforts, many times which we failed on healthcare reform over the years. But we also have to have sort of a pragmatic approach. You know, my frustration having dealt with healthcare for many years now in policy terms is that we often have great opportunities to do a big debate and then we blow it. You know, it was done in 1994 that way. In fact, it's gone on many times in the 20th century where we've had big debates and blown them. So, you know, I think that the fact that you're here today is on a great sunny day is testimony to the fact that this issue is coming back for sure, but also that we need to, you know, be very practical about it and how to, you know, solve the problems. Because we can't wait. We can't let the perfect be the enemy of the good. That's my motto here. Specific on evidence-based care, well, why is that even an issue? The Rand Corporation did a study about 2 or 3 years ago now that showed that about half the time you go to see the doctor, go to the hospital, you're going to receive the wrong care, which is kind of shocking. What they did is they took those guidelines for what is considered the best quality care, which has everything to do with whether you get a mammogram, whether when you're over 40 or 50, if you're a woman, or if you're getting beta blockers when you have a heart attack at the hospital. All these kind of technical things that should be done for us or to us or with us as a patient. And they looked at them and sort of let's go through the medical records of a couple tens of thousands of patients, and we'll see if we actually get the right care. And they found it. And 55% of the time was when people were getting the right care. And so 45% of the time we're getting the wrong care. So clearly, and this is just the part we have measurements for. Most medicine we don't have measurements for. So clearly there's an issue there. And what this means in practical terms, besides having poor health, or less than the optimal health that we could be having, it also means that we probably spend more money than we should. We spend more money in two ways. One, we have too much care in certain areas, and then we have too little care in other areas. And the examples of too little care, for instance, people with chronic conditions who are a big chunk of that 7% of the population that accounts for 75% of the costs, are not getting adequate care. So that, for instance, a woman who has diabetes is not getting proper education, and so instead of paying for a little bit of money to help her manage her condition, she'll get a leg amputation because it wasn't properly managed, and it costing tens of thousands of dollars. Not to mention all the additional social costs of having somebody who's handicapped. And that's kind of where we're at with our healthcare system now. We don't do well. We do pretty well at very specific high cost acute conditions, but we are not doing very well at taking taking care of people with chronic conditions. And so one of the kind of impetuses for evidence-based medicine is beyond just the fact that we should be getting better quality care than we're having, it'll actually save us money if we do the right thing. One of my favorite examples of doing the right thing is the Mayo Clinic. You think of the Mayo Clinic as being a really high-end, really great clinic. Well, it's actually 15% less than the national average in taking care of Medicare beneficiaries. It's a very efficient organization because they do a heavy-duty diagnosis up front, and that lets them determine that they're going to treat the right condition for the patient, and so they don't waste their time and money doing the wrong thing. So that's sort of part of the predicate here for why we are concerned about evidence-based medicine. It's not just the healthcare providers in the field that we need to encourage to do this more. It's also how we work with insurance companies. Insurance coverage. Insurance coverage should be based on evidence-based medicine. It shouldn't be based on just paying for whatever patients want or whatever they doctors think the latest, best new thing is. So we should have, I think, sort of more evidence for how to make decisions in coverage for healthcare benefits. And an interesting, so along those lines, what's happening in Congress right now, for instance, is greater attention to our investment in figuring out, well, what is the best care? What is the best guidelines for healthcare? And so there's Senator Baucus and others are leading an effort to create a new organization that would be investing in how to, it's called comparative effectiveness research. How do we make the best of this information that we have about choosing the right care? And that could help in a big way to make more careful decisions about both the coverage and the treatment that we're getting. So it's a lot of complexity here in terms of how we could actually accomplish that. I don't think I want to bore you too much with all those details, but that's essentially where we need to go, because as you said at the beginning, we need to do the right thing, and that's the key thing.
When you were talking about Medicare and about the Mayo Clinic, that's funny because I printed this article in New York Times. It was April 10th, and it was a study done about different hospitals in the country and how much they spend on Medicare patients. And the most expensive hospital charges $93,000 per patient. And then you look at the Mayo Clinic, who is a well-known hospital, they charge about $53,000. And the reason why, according to this study, is because the more expensive hospitals are doing more tests than maybe at the Mayo Clinic doesn't do. But they also talked about how, our fee-for-service system, and the Mayo Clinic, it says that their doctors are paid salary, so they don't have really a financial incentive to do more and more tests to make money for them. So.
Yeah, that's exactly right. I mean,
Yeah.
salary is one way to help kind of control costs, but it's not the only way. I mean, there's another, even the lower cost area in the country is Intermountain Healthcare in Salt Lake City. They're 30% less than the average, but yet they have sort of a blend of salaries, but mostly doctors who are working on a fee-for-service basis. So it's not necessarily the fee-for-service system. Of course, Mayo Clinic gets paid on a fee-for-service basis. So I think what it is a commitment to doing the right thing, and that's what the Mayo Clinic has done. What they do in Intermountain Healthcare in Salt Lake City. It's a commitment to doing the right thing and being accountable for that in a way that lets people choose that care.
There are two other important factors, I think, that work into this, as David mentioned, doing the right thing. One is the system we have right now rewards specialists and really punishes primary care folks. Where should we be putting our health care dollars? Obviously, if we put it in primary care and education, that's going to pay off in the long run. But we're fast approaching a primary care crisis in this country in terms of, on lots of bases. One is the hospitalist system that's come up recently. Why has it come up? Because we're killing primary care people with the kind of load they get, and they're not being compensated adequately. A second area that is a significant factor is an area that I'm more familiar with, and that is the cost of defensive medicine. We can talk about evidence-based medicine, and yet the latest number that I saw is we spend something like $50 billion a year on defensive medicine. Because doctors know if they don't order every test under the sun, they stand a chance of getting sued. I defended a pediatrician one time who cared for a youngster who nobody thought in the hospital this child had spinal meningitis, so they didn't do a spinal tap. The child died. The doctor talked to me a year and a half later and said, in the last year and a half, I've done 15 spinal taps. I would have done 2 of them based on clinical judgment. I did the other 13 based on defensive medicine.
Go ahead.
I just wanted to say one thing there. There is actually in this country universal health care for one population for one disease, and that is the HIV services for through the Ryan White Care Act. That was grassroots. There was a huge population of people, many of them in 18 to 24, who had no coverage when they were infected early in the epidemic, and they were catastrophically ill from the beginning. And so political action got this coverage through. And in terms of evidence-based, we cover at partnership 16 counties for HIV care. We've had flat funding as we've gone more than 300% in growth, but we've been able to make it work because we apply the standards really strictly. People get quarterly checks. We make sure that if they're on medicine, they're taking them by measuring viral loads and T cells. We have very rigid measurements that we look at every month. We pull out the people that don't seem to be doing well to try to save the money before they get sick. And the amount of money that saved hospitals over the years when everything moved to like a chronic model, I can't even imagine. It's like millions and millions of dollars, I'm sure, for every hospital. So it is a model that that works. And I don't know that it could easily be applied to every disease process, but I think it supports the evidence-based thing that we're keeping people well, and we're also lowering, in that instance of an infectious disease, the public health risk by making sure they're less infectious in their wellness. I would say there's just so many things, but the Kaiser Family Foundation has a primer that lists all the different types, tax credit, federalist, universal, and they all have pros and cons, and it's only about it's less than a 20-page document, and it's really interesting to have you think what would work and what would work in your area. So I just wanted to throw those 2 things out.
Thank you.
You know, one of the other, I keep coming back to this, and I think it's important to look at evidence-based and prevention, and I think that's probably in those models like what you're saying with yours and some of the other hospitals are trying to do. I just, again, I look at this, and one other area is research on disease and the investment on that. I mean, Alzheimer's is a good example of that, where, you know, the thing, again, Dr. Butler often refers to it as, likens it to polio and the iron lung. Alzheimer's is what was polio, and our nursing homes are the iron lung. People live a long time. I mean, in one way to reduce costs of health care is to cure and invest some money in this kind of a research area too. So it's not just the evidence base, but it's also how do we get rid of some of these chronic diseases that that are taking its toll. And again, you'll hear it over and over again, this whole topic is really about the aging of our society, and we've got to figure it out. Because it's gonna, baby boomers are an at-risk population because of the things you said about private practitioners and the versus specialists versus whether it's PAs, NPs. You know, how are we going to structure a system where the people are a part of the process of prevention, the community's a part of the process of prevention, and that we relook how to deliver healthcare services. And I think there's been a couple of comments that you've made that addresses that, but you know, it really is about the whole aging population, and I think research is a big part of that too.
Ron?
If I may, I think Susan brings up an excellent point. One of the more heartrending parts of trying to make economic decisions with regard to healthcare comes down to things like experimental, and that's a tough word, but let me get into that in just a minute. Experimental care. The research is critical to ensure that we move forward. And yet, for instance, if you look at a phase 1 trial for cancer, that's essentially measuring whether or not the new treatment is toxic. Now, does an insurance company pay for research into that? I don't have an answer. I'm raising the question as much as everyone else. When it gets to phase 2, it's okay, is it effective? Not is it relatively effective, but is it effective at all? Does it do anything to treat the condition? It's not until phase 3 that we start evaluating against current processes. Now, the current are supposed to be the evidence-based. We want to practice evidence-based, but we don't want to limit the research. And we want to balance the research by saying we need to pay for some of it, but do we want to pay for something if we're only trying to find out whether or not it's toxic? Those are extraordinarily difficult issues to deal with in a system where we've got a limited number of dollars. And to illustrate, and this is a very difficult thing, and I'm glad you're teaching healthcare economics. I'm an economics graduate. I also did language and literature, so I just want you to know that. I did that first.
You're not completely boring.
I'm not completely boring. I'm just mostly boring.
But it's only phase 1.
That's right. That's right. Some of the difficult things we have seen arise in over $1 million cases. Now, generally speaking, those over $1 million cases are dealing with things that are in a phase 2 type of trial. They don't know, and it's the effective care that you go on back and forth, and then how much of that is part of the current evidence base versus how much of it is the experimental. And figuring out, if you have $1 million, how many diabetics can you treat for $1 million? Now, this is a difficult societal, humanistic, and economic question. But for $1 million spending on an individual who lived 2 extra months, what could have been done for that diabetic? I don't want to be the doctor. I don't want to be the family making the decision. Going back to the purely economic type situation, there is a balance to be made. And that is a difficult thing, and the research is critical, especially as we do have an aging population who are contracting more and more of these types of things. But that is one of the reasons stuff costs more. I didn't have an MRI when I broke my arm in high school. There wasn't any defensive medicine on the MRI because they just didn't have any.
Sure.
You know, and my mom and dad's $100 deductible was the equivalent today of about $750 just in CPI inflation, not medical inflation, just CPI inflation. So we've got some difficult things to balance between what are our expectations, what can we afford, and what do we do with that pot of money? Do we spend it on diabetic care? Do we spend it on that experimental, try to get the research done, or for instance, try to prolong the life of someone that, honestly, the peer review doctor said probably, even the doctors who perform the surgery says there's only a 25% chance.
You know, I think that raises an interesting question, too, and that is whether these problems can be addressed most effectively on a national basis or a state basis. I was listening to NPR recently, and I was listening to a senator who was talking about a thorny problem going on in the country, and he finally said, you know, I don't think we have the will to deal with that in the Congress. We're going to have to leave that up to the courts. And when you see, you know, we've been immersed in this political thing that's going on the last year, and we've got another 5 or 6 months of it where everybody promises everything. But when it comes down to it, what do we do? Are we going to need a system that has some sort of federal funding but is operated on a state level, taking into consideration things you mentioned, places you've been, the locale, people more accountable? I don't know, possibility.
David, I was just going to actually direct you right towards you, because when I was thinking about the national level, I thought you'd be good at answering. Is it better? I mean, is it better addressed at a national level, or can states step in and say, this is what we're going to do? What do you think?
It's got to be at both levels. There's no. So how do you sort the responsibilities is the question. And I wanted to say that in Montana we have a very good experiment going on right now, which is a group of people are coming together from a diverse set of groups, everyone from consumers to labor unions to doctors to hospitals to insurance companies to figure out these very problems on a local level, state level. And we're struggling with all these questions that we're hearing about today, and it's open to anyone who wants to participate. You can go online at montanahealthcareforum.org and see what is being done, and maybe we'll get some results from that. So that is something that Montana is doing, and it's not unlike what all other states are doing, or a lot of other states are doing, which is the fact that employers are just at wit's end when paying for healthcare costs. Consumers are frustrated over the sort of incomprehensibility of the healthcare system, and doctors are probably and nurses are some of the most deflated professionals in the country right now. It's very hard to be practicing medicine right now. So those are the kinds of things we can do at the local level. The national level, however, we do need a national debate over covering everyone. So that, I think, is only the federal government has the levers to really move the money around. Our federal government doesn't do a lot of things really great, but it does one thing really well, which is to move money around very, very cheaply. So I think that's one area where we could look to the federal government to do that.
Ron?
I know our time's nearly up,
that's okay.
but
Go
one
ahead.
other thing to go along with what he said, there are other organizations out there. For instance, I sit on the definition subcommittee of the Cancer Trials Coverage Work Group. And the reason that work group was brought together within Montana, a bill was introduced in the legislature and then subsequently withdrawn to try to dictate, here's what needs to be covered. Well, no consensus could be reached. So on the part, we have insurance companies, we have physicians, we have nurses, we have some of the community-based groups sitting together to try to come up with at least a common set of definitions. We have just finished our initial report. Now the report goes to the operational committee to say, can we turn this into an administrative process that will actually work? And so those types of community-based things are extraordinarily important, because as much as we like everything to be on a bigger scale, the government is efficient at moving things around in terms of funding, but it's not as efficient in coming up with solutions, which seem to be more community-based.
Let me make one point.
Yeah, go.
Susan, you mentioned something I think is right on target, and that is we're not going to fix this thing if we tweak it. We're dealing with symptoms rather than the cause. We need to talk about a systemic change, and I think we could do that very easily. We're talking about evidence-based medicine. What do we do with evidence-based medicine? We set up trials, and we give it some time, and we see what works and what doesn't work. If we would come up with, say, 4 different possibilities of a universal coverage system and put those in place in 4 different major medical centers in the country and let them run for a few years and then see what works and don't work, I think we could come up with a system. I don't know whether we have the will to do it, however.
Yeah, that's a $1 million question too. I think that the people do have the will. It's just whether where the government can come in is the leadership role in pulling that together and making it happen. And I think private ventures need to be involved, and private foundations need to be involved. I go back to the research question, not so much as the way you were looking at it, which is there's a patient who has cancer and you're looking at whether you can afford to cover that experimental drug, as much as just the research itself, where they actually have trials on a certain group of people they've decided, and the FDA doesn't even have any requirements in these research to involve people who are over the age of 65. And yet, most of the people who are affected by things like cancer and Alzheimer's are people that are over 65. And so, and I think that, it's not that I understand everything completely, but I think, there's always this complaints about the drug companies and how much money they get and how the cost of medication, which I know we'll talk about later on, and they claim that, well, that's because we have to invest so much money in research. Well, I think it needs to be where it is a partnership with the government and an incentive aspect of it, so that we can get our brightest people who are working on research and really continue to do the work to cure some of these things or manage them much better than we are. And it's going to be a huge part of whether we can bring down costs. But I also think we're not dealing with the availability of the healthcare profession. You're going to get sick of this, but geriatrics, we're talking about we can come up with a way of accessing, but we're not going to have the people who are understanding the special population and their differences and their needs for health care versus the rest of the general population, just like pediatrics was developed. And there's no incentive at this point for people to get into geriatrics. If we kept a private system and a Medicare system minimally, Medicare has to start reimbursing at the same rate as private insurances. I mean, that's not even dealing with the specialists versus the other, general medicine. We have to re-educate a whole population on how to access assistance. I mean, as we talked about now, I know the nursing students have, and you're going from, the current population thinks that when they call for a doctor's appointment, they should be seeing a doctor. And somebody says, no, you're going to see the PA, or you're going to see this and this and that. Well, what's that versus this, and why is that going to be helpful to me versus seeing what I used to always see as my doctor? And, so there's that whole education on how people should access the way once they get in, how they're managed, their care managed, and it's a joint thing, which is some incentive for people to do what's responsible for themselves. It's all of that. But again, it's all about how are we going to manage this huge silver tsunami, and we should be focusing on the healthcare system and taking care of them, and that will put in place the rest of the population.
Great, thank you.
Thank you.
Well, I think we're going to take a quick break. But, I think the more that we sit here, the more we realize that it really is a complex issue, and I don't think it's just about, structure. I think we as a society need to come together and say we want, health insurance for all. And I think in the election, I think we're seeing more and more fervor about health care, but I don't think we're where we need to be yet to really put it out in the forefront. So I think that's just something that we need to think about. And so we're going to take a quick break. There's refreshments out there. So again, I want to thank everybody for coming. It's really nice that we can bring this panel together and try to come up with some solutions. I know we focused a little bit on the last two questions about, how we got to this point. So now, if we can focus on now towards the future and what we can do to make sure that all Americans have health insurance. So I actually now want to bring up Linda Torma, who's going to give us a little background on the next two questions. Linda has a master's in science and nursing and is a clinical nurse specialist in gerontological nursing. She is also an adjunct assistant professor at Montana State University College of Nursing here on the Missoula campus. Linda has been a registered nurse since 1974, and has worked in a variety of healthcare settings in western Montana since 1978. She currently teaches leadership and nursing and care management, as well as community and public health nursing. She'll be giving a brief explanation on the concept called upstream thinking, which has to do with prevention and promotion. Now, this is going to frame our last two questions. Thanks, Linda.
Thanks, Joe. First, I want to say thanks. This is a great discussion. I'm really enjoying it. It's kind of like I was saying to someone earlier, you teach kids to walk and then you let them go, and this is what it turns into. It's really, really gratifying to be the teacher of these students. It's really a privilege. upstream thinking is something we talk, it's probably for the benefit of the panel more than the audience, because most of the faculty are there. Upstream thinking is something we talk about a lot in the nursing program. And what it has to do, if you picture a river that is winding around, most of our healthcare system is explained as being sort of a downstream solution. Person has a crisis, you pull them out of the river, you fix them, throw them back in. And so it's like there's a crisis, and that's the way we manage things. But if we focus on prevention, we can go midstream, go do some screening ahead of time, or we can go all the way up to the upstream and do some actual prevention, primary prevention, like giving immunizations before people ever get sick. And that's really the point of this upstream thinking. And also, while you're doing upstream, you begin to look at some of the other determinants of that illness. What's going on economically? What we're finding out now is education is a big factor. And that's not something doctors really take care of. And so the upstream thinking is where we need to kind of broaden our scope and our focus if we really want to take a look at curing the downstream issues. And we look at the environment, we look at all sorts of things. So we want to encourage the discussion to move more towards an upstream approach. But there is one twist to this. When I was in graduate school, I was really strong on this upstream thinking because I'm a community health nurse and we talk about prevention all the time. And so I was in the library and I didn't want to write the paper I was working on, so I thought I'd go look at the books. And I grabbed this one called Unraveling the Mystery of Health, and it was by Aaron Antonovsky, who was a medical sociologist. He wasn't a physician, but he taught in a med school. And I read the whole book that day. I was so entranced by this idea of unraveling the mystery of health, because that's what we work with as nurses. And his point was, he was giving a lecture and someone introduced him as a prevention specialist. And he said, sorry, I need to clarify, I'm not into prevention, I'm into health promotion. And I thought, well, so am I. That's what nurses do. We really promote health when people are sick, especially in geriatrics. I was looking at, here's a person with chronic illness, and I'm going to have them feel healthy. So my definition of health with an older adult is not about the absence of disease. It's about how you function and have quality of life with this chronic illness. So there's the health promotion with the geriatric population is a great way to study health for that reason as well. And so I was very intrigued by this. He said, I do health promotion. So he said, let's go back to this river and this upstream thinking. And he said, you know, in the prevention model, you've got the hospital on the bank of the river pulling people out, fixing them, and throwing them back in. He said, if you're in health promotion, and this is where the paradigm shifted for me, we're all in the river. There's nobody on the banks of the river. We're all in the river, and we all are trying to make the best of a fairly precarious situation here. And so our job as nurses, the way I read it, was we need to help people learn how to dog paddle. We need to help them learn how to float and enjoy their time in this river as opposed to rescue them from the river. So that's a major shift, I think, that Susan alluded to, that we've got to think about culturally shifting our expectations of this, what really is an illness care system, to a health care system. And if we want to talk about health, what is that? It's really subjective. Health to me is different from maybe health to Joe or to Kate. And so as nurses, we really focus on the 4 things in nursing is who is it we're taking care of? What is health to that person? What's the environment that they live in? And we look at everything in that environment. And then what is nursing? And as nurses, we look at their functional patterns. We look at things very differently from medicine. We look at how you get through your 24-hour day with this illness. We look at your elimination pattern. We look at your nutrition pattern. We look at your sleep pattern. We look at your cognitive pattern, and that's where pain and your perceptions are in that. Your mental health, your health management. That's what nurses do. And we're very interested in this new healthcare system because, number one, we are not in the CPT codes anywhere. Nursing is bundled with the room at the hospital or the doctor's visit. In that 15 minutes, by the way, all the nursing has to happen too. So when Medicare doesn't reimburse a physician to do med checks or counseling or advanced care planning, those are nursing things, but you know what? There's no CPT code for that because that's nursing. So there's a lot of issues that we need to think about in terms of how we currently do business. Antonovsky also pointed out most of our research is what he calls the pathological model. That prevention model is about illness. We're preventing illness. You would never say you're preventing health. So when you talk prevention, that's a pathogenic model. If you want to promote health, that's what he calls a salutogenic model. So our research really focuses on what makes people sick, with the assumption that if we take away what makes them sick, they will be healthy. Not necessarily so. We also need to look at what makes them healthy, what promotes their health, and that would be salutogenesis. So I turn it over to you to help us move upstream and start talking about the new healthcare system.
Thank you for the nice segue, and I'll go right into it. Ron, I'm going to ask you this question, and then David, if you want to pick up any time as well. The question is, how can our nation make health promotion and prevention a healthcare priority?
It's easier for me to talk about the economics of what, no, I'm sorry. See how boring I am? This is a tougher question because I think this has the most societal impact of any of the others. I appreciate, Linda, your question, what is health? It's a completely different definition as I've gone through. My father is turning 90 this year. My mother passed away 2 years ago at 85, and going through 6 years worth of strokes. And the definition of health for her with diabetes, strokes, and colon cancer was a completely different definition. If she could get up certain days, that was healthy. And so I appreciate that because my own paradigm has shifted to a certain extent about that. If I can address this a little bit with some background, because it's an interesting idea. You've spoken of the illness prevention model. The insurance system, both healthcare and property and casualty and any other kind of situation, it makes a basic assumption. The basic assumption is that the person will take care of their boat, their car, their house, their body, and do all of the things that need to be done on a regular basis, and that insurance is there for catastrophic events. Now that's a little bit of background. The healthcare particularly has changed in the coverage model that now exists under the employer-sponsored healthcare system and under Medicare and other things. It's looking at it, it's saying it's not so much help me cover unexpected, unplanned, unknown events. It's help me take care of myself. And the managed care model of the late 70s through the 80s really started pushing let the provider take care of you. Here's your capitation amount, and you pay $5, and you go in and you get the lube and the oil and everything else done all at once. That didn't work out because they were still being reimbursed in many cases. The capitation didn't necessarily deal as well with the total overall costs of the situation. But that mindset in the American psyche has not yet changed. But there is a dichotomy because we still think, under certain circumstances, that insurance should deal with the unexpected and the individual should deal with the day-to-day. With that as kind of a background, the employer community, in looking at the costs that have escalated, it's over the course of the past decade, 3.5 times is the healthcare cost trend over the regular inflationary trend. So 3.5 times. Each time that goes up, the employers are saying, gee, how do I come up with this? And remember, an awful lot of the reason for offering health care in the first place, there were 2 reasons. One was to be able to give increases during a time when you couldn't give increases, so let's go ahead and make health insurance available because it was cheap. And the other, and this is an interesting thing because I sat on a committee with a prominent employer who said, I offer health insurance so that my employees remain productive. That's why I do it. I want them healthy because when they're healthy, I'm doing what I'm supposed to be doing in my company. So with that in mind, there's been a real growth in the wellness coverage. And it was interesting because when they first came out, wellness programs, it was, we'll give you a gym bag if you exercise. Well, the only people that wanted gym bags were the people who were exercising anyway. I wanted a banana cream pie. And so they had to, there was an awful lot of reviewing what are true incentives. And currently, there's the combination of the carrot and the stick approach. And the idea is, if we're going to keep our employees productive, let's try ways to make people more healthy. And the carrot approach is some type of reward. will reduce your contribution to the health care plan if you exercise regularly, if you take your blood pressure medication, that type of thing. The other one is the stick approach, which is essentially you will pay more if you don't do these things. And the most effective, based on the studies of the wellness industry out there, are a combination of carrot and stick. So it's if you don't do these things, your deductible, for instance, or your cost will be somewhat higher. If you do these things, then you will have that reward. So it's a combination of the two, and that seems to be the most effective. Interestingly enough, though, there has to be a fairly significant dollar value to change behavior. $10 a month doesn't do it, $20 a month doesn't do it. Somewhere between $250 and $1,000, depending upon the part of the company, that's what starts to drive change.
I have a kind of a question on that then. You know, I know David and I were talking a little bit about this in our last class. I know in England, you know, doctors get paid paid based on, can they get their patients to stop smoking, to lose weight, to lower their blood pressure.
Yeah.
Yeah, and I know David was talking a little bit about that earlier, so I don't know if you want to talk about it, and then David.
If I may, there are significant numbers. That's how do you promote healthy behavior in an individual. A doctor can't force someone to do anything. There has to be a motivation for a behavioral change. And if someone's not willing to change, no matter how much more the doctor may make, they won't stop smoking. So part of the issue there is, number one, can we ensure that the individual has a behavioral reason to make some change? And honestly, the financial model isn't the best. I watched what my parents went through and lost 40 pounds, straight up. I watched what my parents went through, lost 40 pounds. My wife's not here, so I'll say this. My wife's father has some very significant leg problems. She was starting to develop those same leg problems. She watched him, she looked at herself, and made some significant healthcare changes in her life. Those were behavioral modification things that had more of an impact than any financial issue, and the doctors didn't have anything to do with it.
And Ron, I think that there's a big part of that might have to do with relationships and the current CPT codes and doctors being able to spend about 15 minutes with their patient. I wonder if that's part of it.
It certainly could be, but one of the other things that's now going on is that employers are attempting to find out who is doing evidence-based medicine. By that saying, okay, if you've got 15 diabetics that you're treating, how many of those diabetics have gotten their hemoglobin checked this last year? And then looking and saying, okay, let's reward. In other words, let's increase the reimbursement model for those for those physicians who are attempting to at least educate. And you see that the only way that it can be done, the education is assumed to create behavioral change, because although the change in smoking, the change in weight habits, those happen on a personal level. The change in who gets a hemoglobin test are generally on the provider level. So it's got to be a combination of both ends.
David?
Yeah, those are all excellent comments, and I think they reflect sort of this, the general idea that a colleague of mine calls, we need to grant people the deed to their health. In other words, we think of doctors and healthcare professionals sort of owning our health, but in fact, we own our health, and we have to take ownership of it. But it has to be a cooperative effort, because it can't be, the last thing you want to do is feel on your own with regard to your health, because it's a very complicated business about taking care of your health. I find it mystifying myself. You see the headlines about this coffee's good, coffee's bad. I don't know what it is. Things with fish is good except if you don't want to do it, you don't want to eat certain kinds of fish because it has dioxins in it. Okay, all right, I don't know. So I like realage.com. If you've been there, but it's a great website where you can go in and fill out a set of questions about what your health is like, and it gives you back personal information about what you should do. And then it sends these little interesting emails about, you wouldn't know about other stuff. Like, for instance, I just learned the other day from this email that said, you can drink all the green tea you want, but you're not going to get the antioxidant effects of that unless you also have it with citrus. So, who knows? Who knew that? But that's the sort of thing that we have information overload in our current society, which is great. We have more information than we know what to do with. We need to have filters for that so that we can begin to personalize that information. And sort of the view of public health and promotion should be in the future about not just having abstract, sort of don't, the basic public health measures are, don't smoke, don't have safe sex, don't drink excessively, a few others. That's sort of, okay, we know that, but that's good to say in general. But, all the other things you have to do for your health are much more personalized. And so to sort of connect this then with what employers are doing, the kind of things that we just heard about are when you go into a health promotion plan at your employer, the first thing you will do is fill out a health risk appraisal, which is this realage.com. And you fill this out, and then you get personalized information fed back to you. Now, that's not enough to change your behavior, and the science of behavioral change is actually pretty well established, as I understand it. You first have to have an intervention, some reason to intervene. Then you have to have an intensive counseling so that there's some support for the person to learn how to do the changes. And then finally, you just need to have kind of automated follow-up for that. And so you're giving them automatic reminders to make sure that they get these things done. Dentists are great at this. I think dentists have really, have a good model for this. I get my postcard every 6 months, and they go to the dentist. Okay, all right, I'll go to the dentist. But that's just a very simple idea, but they've really ingrained it in our heads, and that's how it works. So, example of how to put all this together is in King County, in the Seattle area. The county executive there, Ron Sims, led this effort to sort of stratify your health engagement in your health through sort of the Olympic kind of medal. So you would get a bronze medal if you took the health risk appraisal. You'd get a silver medal if you got if you started doing what the health risk appraisal did, and you got a gold level if you showed results. And then these actually were not just medals, you were actually related to some kind of financial benefits like you had lower deductibles and so forth, just to reinforce it. It wasn't the financial incentive itself that made the difference, but it was sort of using the financial thing as kind of a reinforcing of it. So that can be done. That could be done, it's becoming a national model. It should be incorporated in our healthcare reform efforts when we decide what the benefits package is going to do. And so that it really can work.
Okay. Go ahead.
I just want to say one thing quickly, and this is more from the poet side of my life maybe than the nursing side, but I do think none of this can happen without a huge culture shift and a generosity of spirit towards people who are unable maybe to make changes quickly, and to recognize that people raised in despair and poverty don't necessarily make change at the same pace that someone who has had more opportunities. The other thing is, I think, to acknowledge, are we willing to have, as baby boomers, maybe delayed gratification, maybe not be first online for a kidney transplant as we age, or, how are we going to measure? I have many cousins in Ireland who I talk to on the phone, and my 71-year-old cousin a couple of years ago, who loves to read, starts describing perfectly cataracts. And I said, Andy, you have cataracts. You have to go to the doctor, and they can fix it. And so the next Sunday he called me and he said, well, she said, don't come back unless I've been shot in the eye. There's too many people that need the cataract surgery. And he patiently waited and essentially almost lost his sight. It was over a year before he got the cataract surgery. But it didn't occur to him to challenge that he was entitled to more. And I think that will have to happen if we're honestly going to say that we're going to take care of our brothers and sisters in the society. So I'm just throwing that out.
May I add one more thing, and this is where additional research, and I think particularly in the aging population, there's not enough said about how to ensure the mental wellness, particularly of an aging population. But for that matter, of the entire population, we speak of the explosion of depression and so forth. There are those who say, well, it's because there's an ICD-9 code for it now, but that's not necessarily the case. And understanding that part of the wellness model has much, much more research to be done.
I just want to say one thing, because I was kind of thinking about this earlier. I just got my premium for on my car insurance, and every I don't know, maybe 6 months I get a bill, and they decrease, the amount of insurance that I pay based on am I accident free. And I don't know, do we have a system now where if I stay healthy that my deductible can go down instead of being up? Is that something that we need to think about? And if not, why not?
Health promotion is really an extraordinary shift in the dynamic. Right now, the entire tax-based system only allows deductions if you meet certain non-discrimination requirements. And one of those non-discrimination requirements is that you cannot change the benefit based on the health status of the individual. So you can't even make it better, with certain exceptions for bona fide wellness programs that meet certain criteria, and other limited benefit fully insured programs. Those are the only two exceptions that allow for a differential in benefits.
David?
Yeah, that limitation is not is bigger than it sounds at first, but because it is producing significant results. And I think the interesting thing about this health issue is that both it's sort of nonpartisan. Both political parties I've noticed are talking about this as a political issue, that we have to do more to take responsibility for our health. But just saying that, so people know, that they have. If somebody's overweight, they know they're overweight. That's not the issue. You don't have to lecture somebody about that. You need to create the conditions for them to make the change with the patients and the it's encouragement that should happen. So yeah, the example I gave with the gold, silver medal, bronze levels, that is an example of what we're talking about, giving people a financial incentive to improve their health, right?
Yeah, and I think
but you don't want to go too far, because you don't want to penalize people for, if people have genetic conditions or have other, just bad luck kind of situations. You don't want to penalize people for that.
And I think that's a good point. Like, health promotion doesn't necessarily mean that you have to stay in perfect health. How can we promote the health of those that are already sick by including them in healthcare access? How do we get rid of the pre-existing condition that a lot of people are forced to not have healthcare access because they are sick and can't get better now?
Well, I was go back to the livable community concept, that there's plenty of health promotion kinds of activities that people can choose from and go and access and get support. I think you mentioned a big part of that, the mental health aspect of it, because you can give a person a pill or insulin or whatever, but if in some cases whether it's obesity or whatever, it can be psychological issues that have to be dealt with simultaneously to the treatment of the disease. And of course, if we really want a complete system change, we have to look starting in the school system. I look at just how it was kind of fascinating to me to watch the whole issue of the country is overweight, we need to lose weight, and finally all of a sudden you start seeing McDonald's offering salads and low fat and things like that, and you go to some other restaurant, they have Weight Watchers, and and it's just, it starts to permeate the culture. So, but like most things, if you can ingrain it in children when they go in, it's not, you don't need the incentives here or there. It just becomes same as putting your seatbelt on, and so we really have to invest more, which is kind of interesting since, we've done that with sex education clearly as an effort to try and reduce the amount of kids getting pregnant or sexually transmitted diseases. But it's interesting, we seem to have less time at school about health promotion and exercise. Of course, when you look at a middle schooler wanting to learn about the nutritional value of something, they're not paying attention. But it has to start from the beginning. Instead of schools moving away from health education, they should be making it more of a prominent part of the curriculum.
Great, thank you. I think we're going to move on to the next question, because I know at least a couple audience members want to ask a question towards the end. So we'll go ahead and move on to the last one, and then if not a lot of people have questions, we can keep on going. But so the next question, Susan, I was going to address, or we were going to address towards you. How can our nation influence the increasingly unaffordable cost of prescription drugs?
I guess a couple of ways. One is I think we have a system to do that. Let's assume that we have we get our universal health care coverage, again, based on similarities with the VA system and where some of the studies, whether the physicians are salaried or whatever the case is, that helps set that system. But clearly, the Medicare Part D prescription program really, well, if there was an argument for the private sector, it was a good example of showing how the private sector would exploit and blow it. So the idea of the government not having any involvement in negotiating drug costs, we talk about economics, I did pass that class, by the way. But it was, it's volume. If you negotiate volume, then typically costs come down. The other thing I think that's what insurance companies, drug companies are saying is that they charge so much because of the cost of research, to develop the new drugs and do all those kinds of things. Well, then that's where I think private foundations, government, in partnership with pharmaceuticals, you kind of have to have a meeting of the minds of the purpose of medication and research and the value of it. And I don't want to make profit a dirty word. I mean, sometimes it's like how much is enough. But
should we pass a law then? I mean, that says that, I don't know how we would do that, but
Well, I think it's part of that whole discussion when we look at how do we shift the whole systems change in healthcare. It's how do we involve the pharmaceutical companies and provide an incentive for them to do the right thing. Because from my personal opinion, it seems like there isn't a lot of incentive for them. And maybe it's not even the pharmaceutical company as much as it is the middle person. I use, again, the Medicare Part D, and you have all these insurance companies. I mean, in the state of Montana, we had 51 choices for seniors to choose from, and they weren't even standardized choices. And then you get people who they get exploited. They show up and say, oh, I'm a Medicare D person, all you have to do is sign here, and all these scams going on.
So what's the answer then, do you think?
The answer, I do believe, is to look at something similar to the VA system where volume and the government has some negotiating power with the pharmaceutical companies, and then providing some incentives for research that is in partnership with the government.
Okay.
Do you think that the current Part D should stay as it is?
No.
Okay. What would be your solution to that?
Well, gut it to start with. I don't want to deny the fact that people who have not been getting medications are now getting medications. So, and getting them and at an affordable way. But I think that the ship was built, and like anything, when they say it's an act of Congress, one of the reasons there was such conflict when it came about was because part of the aging community and advocates wanted just to go with it. It's better to have something than nothing. But as you all know, typically with government, once you start, it's hard to change it, and that's in fact what the case is. So I think it needs to, number one is the government needs to take back some control in terms of negotiating for the drug costs. Really is no reason why they can't set it up similar to when you turn 65, or in other cases when we get older before we can get it. When you're eligible for Medicare, just like you have the A, B, add D to it, you have so much you pay for it, and everybody gets the same standard approach to it. You can also do, like in the Advantage program, you can offer people the opportunity to buy up or whatever, but standardize it. So kind of like the supplemental health insurance, all A policies will give you this, this, and this, so that you have something to compare it with. So I would, yes, scrap it, the privatization of it has really been very detrimental to the patient.
David, do you know where we're heading as far as prescription drugs? And I know we're talking about Medicare and everything else, but I just picked up some prescriptions the other day, and it was 30 tablets, and I spent $168. And I was to the point where I wasn't sure if I was going to get it. I put it on my Visa, and I guess I'll worry about it later. But do you know where we're heading?
Well, it's,
Or where we
okay.
should head?
There's a lot to be said here because, I mean, the first thing I want to say, though, is that as a Democrat, the Republicans produced a Medicare prescription drug benefit bill that we couldn't. Right? I mean, you got to give credit where credit is due. I mean, I think that they did it for completely political reasons, but they did it, and they produced something. It took Medicare 30 years to have a prescription drug benefit when employers were providing prescription drug benefits long before. I mean, I think we have to sort of, as we're rethinking things, rethink how much centralization we want versus how much innovation we want. And I think that one of Medicare's weaknesses is that it's not innovative. It does lock in what prices are paid to doctors so that specialists get a lot more than primary care doctors, and it's very hard to change it. So with regard to the prescription drug benefit, I mean, I think we got bigger fish to fry here. I think we should go on.
Okay.
But in terms of, political agenda. But I do think there's a lot to be done on prescription drug costs. And I mean, the two sides of the coin are, well, prescription drugs do save money because they produce, they're cheaper than surgery, for instance, that sort of thing. But at the same time, we're still paying a lot more than we should for things like for brand name drugs when there's a generic available. And one of the interesting things that could easily be done, and it's part of the health information and technology movement, is that if doctors right now are still writing out prescriptions by hand. Mm-hmm. It's got fraught with problems because the pharmacists still can't read it. So there's an idea, let's get the doctors to put that on a computer. You just write it, have a pop-up menu of the drugs, you can just list that, okay? That would be a lot better, and in fact, there's a bill moving through Congress that would, first of all, encourage it, a carrot-to-stick approach. First, it would encourage it, and doctors require it. They'd be required to do this prescription automated system. So what you can do with that system then is when a doctor today doesn't even know what the patient's health plan is. They sometimes can look up in their PEDA what the formulary is, which is the drugs that are approved for the particular plan that the patient's in. But with the electronic system you could do is to have the generic pop up as an alternative immediately if that was indicated for the patient, and specifically for that patient, because we know that drugs do differ from different people, but we know how they differ in a lot of cases, so we could have that pop up. So we could have a lot more increased use of generics, and then for that patient, if they want to have the brand name drug, fine. But right now, they're paying, we'll subsidize, the Medicare program subsidizes most of the cost of that that brand name drug, even if the generic drug is perfectly acceptable. So let's have the rule be you just get paid for the generic and not for the brand name at all. If you want to buy the brand name, fine, you can do it, but it's with your own money.
Okay.
Well, I guess, I don't disagree with that generalized approach, except that, it's not that easy. You look up in the formulary, and maybe this month they cover it, but next month they could drop it. And then there are the process of having to go through and determine that, no, I've already tried that generic one, and it really doesn't work. And we were talking about a Medicaid patient or something of the sort, they have to have the other drug, and it takes forever to negotiate to make that proof happen. So, I just think that the insurance company seems to have much more, it's really, they have the greatest flexibility, and the patient has the most restriction. And that kind of needs to change. I don't disagree that the physician could sit there and electronically say, okay, it covers this, we can do this, you could use generic. Of course, I wonder how many of the doctors will take that much time to sort through those things. That's where those nurses maybe could come in. But I just think that you got to look at how much those individualized insurance and pharmacies are making off of the current medications that are out there, and so the system does need to change, and not just the technology to access it.
I'm going to stop us there for just a quick sec, and I know there's some people in the audience maybe want to ask questions. I know of at least one. Go ahead.
Go ahead.
I enjoyed the discussion and I learned a lot. And, some new things I hadn't heard of the term.
Sir, could you go
Fancy.
use the, could you come up here and use the mic, because we are taping it. Sorry about that. Thank you.
I hadn't heard the term defensive-based medicine until Larry Riley brought it up. But the idea of also evidence-based medicine, hadn't heard it quite in those terms. But I'm wondering specifically if both of you, David and Larry, can address, and also Ron, if you'd like to weigh in on this, since it seemed obvious to me that these things have been around, though, for a while, and they're not working in the present system. The alternative that we have, and which has been mentioned a couple times, universal health coverage, which is what SICO was really about, was showing that this present system wasn't working. We need to look at, will universal coverage, how will it work to bring about less of this problem of defensive medicine, and will it, can it do a better job than the present system? And likewise, will it encourage more of a doctors to practice this, what you're talking about, evidence-based? Because I think that's what we really need to talk about, is how are we going to go forward and change this, not just discuss these as being highly complex, but if we have a choice of another system, an overhaul, a new way of thinking, which would involve, as you're saying, a change of cultural thinking, and we are going to have some of that. How will that make this better? If
Thank
you
you
could
for your
address that,
question.
please.
David?
Yeah.
I know we kind of talked about it earlier.
Well, yeah, this is a great question, because I think it's a balancing act for how much you want to change healthcare. What happens when we try to do a big change all at once is people get scared. Yeah, because most people have coverage today, and if you threaten that, then they're going to find out they really like it, even though they're always complaining about it. We're always complaining about our healthcare coverage. Well, it's terrible until somebody tries to take it away from you. So the trick, but yet if we do too little, just covering a few more kids this year again, which is a great thing we're going to have on the ballot initiative for Montana, which is, I hope you all will support that. It would be great, but that's not enough. I mean, most adults that are in poverty in this country don't get anything. So we got to do something more, bolder and faster. So I think the trick, and also I just want to speak to the issue of SICO. I think SICO was a great movie because it showed us that we really need to care for each other and do it much better than we're doing it today, and that it's nothing scary about doing that. It's very, very normal, in fact. But the idea that we simply can, do what the French do or do what the Canadians do, that doesn't really work for us. We come from a different political tradition than countries that have parliamentary systems of government. They had monarchs before they had parliaments, and in parliaments they have a prime minister, and one party is in charge at any given time. And so there's, who's accountable. You can, if something goes wrong with the healthcare system in Canada, you know which party to blame. In our country, with our divided system of government and checks and balances, if something went wrong with our healthcare system, the Democrats would blame the Republicans would blame the Democrats, and we wouldn't get it solved. So we need to model our healthcare system more like in the checks and balances system, where people we assign responsibilities, and people have different roles. So individuals should, for instance, have their own choice of coverage, but the government should make sure that choice is affordable, as an example. And that's an idea that exists in at least the two Democratic candidates on the presidential level, giving people more responsibility, but also the more tools that they need to fulfill those responsibilities.
Thank you very much.
I'd echo what David said in terms of we all as human beings have a fear of the unknown. It's why people will stay in abusive relationships, because it's an abusive relationship, but it's a known as opposed to the unknown of getting a divorce. So we have that to overcome. Our system right now, I think maybe the biggest detriment or the biggest hurdle to changing the system is there is an incredible number of vested interests. You start looking down through all the people that make money off the existing system, and my profession happens to be one of them. And people say, well, you know, what really motivates people? Ron talked a moment ago, what really motivates people? Get their pocketbook. Throughout the history of humankind, if you can find out who's paying the money and who's getting the money, you'll find out the reason for most decisions. Now, to address your question more specifically, would this universal coverage reduce claims? I believe that it would for a number of reasons. One very important reason is that we see claims filed now. People go into the hospital, and if they get a bad outcome or they have a complication, maybe there hasn't been negligence, but what are they left with? They're left with a huge medical bill. I defended a case recently where the medical bill alone was $1 million. And what are people going to do? Where are they going to turn to that situation, particularly if they don't have very good insurance, they're not insured or they're underinsured? A very common place to turn is, let's file a claim. And so, you know, which comes first, the chicken or the egg? If we had good universal coverage, maybe that wouldn't be an option, that they have to file a claim. Maybe a variation would be some sort of no-fault reimbursement. Now, I had an insurance person tell me one time that we can insure any risk in the world. There isn't a risk in the world that we can change, or not insure, if we can figure out where to get the premium. Where are we going to get the money? So it all comes back to that.
David?
You know, I got carried away with my answer. I forgot the most important thing. Evidence-based medicine began in Canada at McGill University. It was the first frame there many years ago. And the real point here is that all countries, regardless of the healthcare system, are all struggling with how to implement evidence-based care. So it doesn't matter how you pay for healthcare. In the general sense, I've heard various countries do it. It's a mindset change that has to happen no matter how you do it. So we're all every country is struggling with this and figuring out how to do it. And we'll probably do it through incentives and through, through educational processes, and Canadians can just kind of wave a wand more or less and make it happen. They're just to have more of another way of doing it. So.
Okay. All right, thank
Thank
you.
you for your
much.
question.
I think maybe one more, if everybody wants to get out on time. Anybody want to ask a question? Excuse me? Oh, does anybody about S-CHIP? We had one speaker that was supposed to come today, Janice Van Riper, and she was not available to come due to some illness. And David, do you want to talk a little bit about it?
Sure. The idea is that nationally the numbers are 9 million kids don't have health insurance. Now, about two-thirds of those, about 6 million kids, are eligible for a program, but either they're not signed up or the money is not quite available, so there's not a big aggressive effort to get people signed up. And so these are mainly kids that are, children of working parents whose employer may cover their own individual coverage, but it doesn't have dependent coverage. And so these are, folks that are, low to moderate income folks that don't have adequate coverage right now for the kids. So what will be on the ballot initiative in this fall will be, hope if we get the signatures done for the ballot initiative, is a proposal to expand SHIP, which is the Children's Health Insurance Program, was started as a bipartisan program in the mid-'90s, and so to take that eligibility, right now it's at 185% of poverty in Montana, and it will take that up to about at least to 200% of poverty and more. People will have a choice of getting their coverage directly through the government-sponsored program, which is operated in Montana through the Blue Cross Blue Shield Association, or they can get the coverage that might be available to them through the workplace, even if their employer is not covering it directly. And it's also going to then be a budget battle, because we'll want to make sure that we have the money for this. But the draft ballot initiative is fairly ironclad. It's actually going to force the money to be spent. So if we get the ballot initiative done, then that will guarantee that we'll have probably at least two-thirds of those kids covered in Montana.
All right, thank you.
opposing point of view on it.
Is there anybody here? I don't know. Who's opposed to coverage for kids? I mean, the only opposing sort of point of view is that, well, what else should we be spending our money on, perhaps? So that's the question. And I would argue if we spent about $100 million on a tax rebate last year in the legislature, we could spend just all this would cost would be $22 million. So that doesn't seem like too much to give.
If we're going to continue talking, can we have microphones?
Yeah.
Yeah, Bryn, do you want to? That'd be great.
Question.
Okay, great.
So how are we going to meet the Bush administration's requirement that we are currently covering 95% of those eligible children at the current, I believe it's 100% of poverty level, in order to qualify for the matching funds from the feds?
The rule that the Bush administration is trying to implement is to say that you can't go above 200% of poverty in your eligibility for S-CHIP unless you have 95% of your kids covered. So that we would so the bill, as it was read, the draft language says, take it up to 200% of poverty at a minimum, and then as the federal funds were available, presumably that rule won't stand, assuming the new administration, I think, of either party, taking over a new president. I don't think those will stand, and so hopefully we'll have the ability to go higher than that. But if we could, I mean, even if with those rules in place, we should be able to get to 95% of coverage. If we can't get to 95% of coverage for kids who are in poverty or who are near poverty, we have failed. So I don't like the rule. I don't think we should fight it. It probably will change, but that's not a reason to stop trying to do that.
I guess one of the things, I like the comment that Mary Jane made regarding the issue about looking at the vulnerable populations and understanding that there are going to be some people who can't make changes rapidly, et cetera. And I think it goes back to the whole issue also of health promotion. And when you look at the working poor, these are individuals who are frequently working more than one part-time job because they can't find an employer to give them a full-time job. So they're working more than one part-time job. If they have children, they're trying to parent their children. Doesn't leave a lot of time to do those things about what we call health promotion, like making sure that they get adequate exercise, et cetera. Particularly when you talk about a rural community where there are also additional barriers. And I guess that follows also along the line with the barriers with the CHIP program in terms of making parents aware that it's available, getting them to realize that that their children are eligible, and then making it easy to sign up. How do we make it easier to sign up and participate within communities? And I really see this as a community driving piece. And if we want to talk about the states helping do that, what kind of leadership do we get at a state level to assist individual communities in making that happen?
I don't mean to dominate the discussion here, but I'll just answer that quickly. I think there's at least two ways. One is that if a child is already participating in a school lunch program, for instance, or a welfare food stamp program, let's make them automatically eligible for CHIP. Another way is to have enrollment partners like already exist in Medicaid at the hospital level. If you go into a hospital today and you are eligible, they will find out if you're eligible for Medicaid if you don't have other coverage, and that's an enrollment process that the hospitals are very interested in participating in because they can get money that they otherwise wouldn't get that way. But why can't we do the same kind of thing with all our other social service agencies and having those people who already have a connection with the kids, if they're in the schools or in their various social programs, give them a sign-up bonus. This is what a lot of states do, so they can get them enrolled because they're in contact with those folks. And then I think the third thing, it's not really discussed in those two things are in the referendum. The third thing that's not really discussed in the referendum, but we could do easily administratively, is to do online enrollment processes, which a lot of states have done, just to make the job of the filling out the forms easier. Mail-in, and I'm not sure if maybe we are doing this in Montana. I'm not sure. Mail-in applications, that sort of thing.
All right, thank you. I promised everybody that we'd try to get out here on time, and it is 5:30, so.
So we need to wrap up, but I'd just like to say that these discussion questions are huge questions, as you've heard, and the answer is obviously not clear-cut. It's a complex, very messy issue with lots of different interests at stake, like Larry said. I would just like to say, if you take anything home from this discussion, it's that it's up to each and every one of you to take action. You know, this government was founded on being run by the people, and I think a lot of people think it's impossible. Our government will never change. Well, we are our government. It's up to us. So educate yourselves, educate your friends, your family about the issues. The program contains a few links if you want more information about these issues. And get involved. There's a lot of opportunities right here in Missoula. All you have to do is look. And finally, like I said before, vote. That's really the #1 action. So I hope you guys all learned a lot. Thank you so much to our panel members. We couldn't have done it without you. And thank you also to our sponsors. This couldn't have happened without the support of Montana State University, as well as the University of Montana, the College of Nursing at MSU, as well as the MSU Student Forum. So thank you, everyone.
And thank you, Bryn and Jess, too. They've been helping us
Thank
a
you
lot
so
for the
much.
last 3 or 4 weeks, and we definitely could not have done it without you guys.
Thank you.
Thank you.